Okay, Eberhard, it is our definite pleasure to be able to transmit this case from here to Hyderabad. How is the weather in Hyderabad?
It's always nice in India, so no worries. We're sitting in here safely.
Okay, so please let me introduce you our team. So as you can see, Geza is standing right next to me, my friend. My friend, please the camera, please show us Geza. My friend, and a very important member of the team is Balazs, who is standing right behind us. He's a heart surgeon. He will have a very, very important and significant role, you will see. But at the moment, I want to keep it in secret. Why? We will discuss the entire case, and then hopefully you will understand why he is here with us. So Anna is our scrub nurse, standing here. Keva is the anesthetist, because it is general anesthesia. You will understand why it is important. Monica is our imaging guy. She will be the cardiographer. As you can see on the monitor, we are going to be using the transvaginal echo because the patient is intubated anyway. And we have an electrophysiology fellow because the patient has a pacemaker. And Noemi, our young cardiology fellow, will explain the patient to the audience and to you. Noemi, it's your turn, please. Would you please fix my mask? No? Thank you.
These are our disclosures. Can you see your slides?
Yes, we can.
Eberhard, can you hear me?
Yes, we can.
Okay.
So this patient is 79 years old. She's a female. She has hypertension and type 2 diabetes. She also has a permanent atrial fibrillation and an end-stage kidney disease. In 2014, she underwent endarterectomy due to the significant stenosis of the left internal carotid artery. And then in 2016, a permanent pacemaker was implanted due to a third-degree AV block. Her aortic stenosis is known since 2020. At the end of last year, in 2023, she was presenting symptoms of heart failure, and her aortic stenosis became significant, so she was hospitalized here. During the hospitalization, anemia and positive stool blood tests came back. So we ran some diagnostics, and we found gastric ulcers. In the CT this year, in January, showed a left atrial appendage thrombus. So on the echocardiography, you can see that she has a good ejection fraction of 75% with a calcified mitral annulus and a mild mitral regurgitation. We also saw a moderate tricuspid regurgitation. The aortic valve was heavily calcified with barely opening leaflets, and the peak to median gradient was 88/47 millimeters of mercury. The AVA was 0.2 centimeters squared, and we also saw a mild aortic regurgitation. On the CT scan, we saw the mild sclerosis of the right coronary artery and the circumflex artery, and we also saw a moderate to severe LAD stenosis. Here you can see the CT scans of the left atrial appendage. The yellow arrows indicate the thrombus. So as per our institute's regular ways, we brought the patient in front of the heart team.
Okay, so that is the case. To be honest to you, this patient was our second patient in line because we wanted to show you a coronary patient together with the TAVR implant, but due to logistical issues, she became the first patient, and we think it's also a very, very interesting case. So there is actually a big question at the moment. I mean, what we should do is very obvious, that since we are unable to anticoagulate this patient, we need to close the left appendage. But there's a thrombus sitting in the left appendage, so which is a clear contraindication for the percutaneous closure. So that's why we decided to close the appendage surgically. And of course the TAVR is also indicated. It's a very, very tight aortic stenosis, as you could see. I can see the gradient. Please show us the hemodynamics. So we can see the gradient. The gradient is pretty high. And the aortic valve area is 0.2. So it's really, really tight. So we decided not to close the appendage first in the OR, but let's fix the aortic stenosis first, and in the same setting, let's close the appendage surgically. So that is the plan, Eberhard, and what do you think? Is it a good plan or a bad plan?
I would never dare to say this is a bad plan anyway. So, you know, now we understand why the heart surgeon's in the room. It's actually a quite interesting approach, because you know, you do the TAVR first, and then then you close surgically. So the question is, if you are doing surgery, so why not replacing the valve? But I understand the approach. I wonder what the panel is thinking. Any thoughts on how to proceed in this case? This is a very interesting case to discuss, actually, Peter.
Yeah. Just let me give you two more sentences. Why don't we go for a surgical aortic valve exchange, right? So that's what you ask. It's a pretty frail lady. She's 80. She was 80 yesterday. So yesterday was her 80th birthday. And this was the very obvious decision of the heart team that they shouldn't go for a surgical aortic valve replacement, but a TAVR.
Yeah.
And the appendage closure will be surgically. Balázs, do you have a mic? Would you please explain what you're planning to do? So it's going to be kind of a semi-invasive surgical closure.
Yeah, that.
So it will be a total endoscopic left appendage closure. So we will have two parts, and it's a total endoscopic way with the 3D endoscope and with the Atriclip Pro V device because of the presence of the left appendage chamber. So we will clip the left appendage.
Yeah.
So we want to be as non-invasive as just possible.
Yeah.
Eberhard, it's your turn. I'm sorry to interrupt you.
No, that's well understood. I think that's a very, very reasonable approach, because the damn thrombus in there, you can't ignore it. Mm-hmm. You know, you have to deal with it. So this is very interesting. I think I see. Yeah, go ahead.
High risk of wall thrombosis is also there after TAVR with this LA clot and LA clot, and it would be a problematic after TAVR.
Yeah. Yeah. So Peter, I know that you know we have 30 minutes. 15 minutes left. So I know that you are a fast operator with your team, but we would really see something, and I wonder, you know, what the next steps would be as far as valve choice and.
Yeah.
And, I'm not sure. Did we see the calcification of the?
Not yet. No, not yet. We will.
Okay. I'm sorry.
The next slide, please. The next slide, please. Okay, so as you can see, that it's going to be a 26 millimeter Evolut Pro Plus. That is the plan. And as you can see, that the minimum diameter is 19.6, and we plan to pre-dilate this valve with an 18 millimeter balloon because it's a very, very, very tight anatomy. Show us the other slide, please, the next one. So as you can see, that this valve is pretty calcified, but there is a very calcified bridge around the edge of the non-coronary leaflet. The other leaflets are not that calcified. The next one, please. So these are the coronaries, pretty good coronary height. and nice and patent coronary arteries, the next one, at least the orifices. We are planned to have some femoral issue. We decided to go for the left femoral. So the large sheet is in the left femoral. It's a 14 French sheet. It's in the left femoral artery, and we have a 6 French sheet in the right femoral artery. The anesthesia is using the left radial artery, and the next one, please. So the TAVR first, and the thoracoscopic surgical appendage closure will be in the next one, the next slide. So the Evolut 26 Pro Plus, and Balázs will be using an AtriClip Pro V for the closure. The next one, please. This is the team when we were much younger. It was in 2008. Right after our first TAVR implant.
You haven't aged.
Thank you very much, yes.
You haven't aged, Peter.
Oh, well, thanks. At least I'm trying not to. Would you please fix my mask because I'm talking too much? Thank you. Thank you. So, please, megfutatod, and please show us the angiogram, the first angiogram.
So can I ask you a question? Can I ask you a quick question, Peter?
Oh,
the calcification, at least in one image, I had the thought that, you know, it was reaching down into the outflow tract, or was I wrong?
No, the alveoli is free.
Okay, good.
The alveoli is free, and as you can see, there's the sentinel device in place.
Very good.
The appendage thrombus is definitely not a contraindication for a TAVR procedure. That's what we all know. But we are going to use rapid pacing for the pre-ballooning. And there is a very slight chance that when we change the heart rate, the thrombus will move away from the appendage. And we don't like that. So that's why we decided to go for the sentinel device.
Yeah, this is very good. I'm just wondering, when you're pacing, I mean, the patient does have a permanent pacemaker, but if you're pacing and you rapid pace, supposedly 180, and you stop pacing.
Yes, that's the plan, yes.
Yes, so that would be something, all of a sudden the heart kicks in, and that might move actually the thrombus. So,
yes.
I don't know what your plans are, but in this situation, I would probably slowly reduce the pacemaker rate. And then let the pacemaker take over. But it's very interesting. But I'm glad you're using the sentinel, Peter.
Yeah, that is the plan. As you can see, well, would you please just take a look at the bovine. So it was not easy. It's not impossible, but it's definitely not easy to properly position the sentinel device. But I think it's a pretty good position for the cages, for both cages. Anyway. What about putting the Landaquist wire? We are going to use Landaquist wire because we are prepared for the femoral iliac difficulties. So let's do it.
While you're doing your job there, any comments as far as the valve choice is concerned? Because at least there's some good news in this poor patient that the coronaries are at least okay, but. The access seemed to be feasible, right, Peter?
Yes, the access seems to be feasible. It is calcified, but since we always go for an ultrasound-guided puncture, with the ultrasound, it's just easy to avoid puncturing the calcific plaques. So we don't, to be honest to you, we are prepared for the difficulties, but I do not expect any significant femoral difficulties during going up with the device.
Yeah.
The puncture is ultrasound guided, I think so?
Yes, definitely. Yeah. Both are ultrasound guided. It's a must. Okay. Yeah. Definitely. So I think that nowadays, I mean, we are a radial center. But even if we have to use the femoral artery as a bailout for a PCI, it has to be, it's mandatory for to go for ultrasound guided puncture, even for PCIs.
Yeah.
Severe calcium.
Okay. So the balloon in place. Próbálom majd lassan csökkenteni. Christian, can you, we can start the placing, but please go up gradually and please come down gradually, okay? Yes, please start. Okay, so we have started the pacing. The device, of course, needs some time. The balloon plays. Very good, balloon down, and please decrease it gradually, okay? And the pacing rate is coming down. Okay, okay. Geza is coming out with the balloon. Perfect, stop pacing, because this is the patient.
You can increase the heart rate, no problem by the...
Yeah.
What was the balloon size?
The balloon size was 18.
I see.
The minimal diameter is 19.6. So that's why we decided to use an 18 millimeter balloon.
Yeah, that's great.
So, okay. Good. So the sheet is coming out, as you can see. Would you please show us? Oh yeah, you can see my hand. Very good. So the device is coming. Very good. I've just plugged. Okay. So the flash port is towards like 3 o'clock. So please show us the groin, Anna. The groin, please.
Yeah, so that's
very good. We're going up with the design. Show us the wire in the LV.
alignment.
Very good. It's a good LV position. Go down to the valve. Very good. Right, please. Okay. So I stopped here because we are still in the descending aorta, and this is the last and safest point when we can check the position of the flash port. So the flash port is still towards 3 o'clock, so then we can proceed. It's very important for the commissure alignment.
Yes.
Okay,
Yeah.
so we are in LAO. So we are going through the arch, and please concentrate on the head marker, okay? The head marker is in the outer curve, so it means that the commissure alignment, hopefully, is pretty good. So please come back to AP Anna, please.
Head marker at the outer curve and flash
yes,
port at
head
3
marker is at the
good.
outer curve, so that's good.
Yeah.
Okay, so we are crossing the valve. Very good. Let me see whether the pigtail is free. Yeah, the pigtail is free, so it's in the non-coronary cusp. And we are going to the cusp overlap. Would you please fix my mask? Thank you. Thank you. Thanks.
So
again. Yes.
So you put the marker. Yeah, you put the marker at the pigtail
yes,
height, right?
Yes, I'm going down to the mid-pigtail level.
Yeah.
Yeah, that is the plan. It's a Lundquist wire. So let's go for an aorta. Anna, please, a bit more caudal, see, because it's, we need to kind of modify the cusp overlap. Please come caudal a bit. Because it's a ring and not a line. So we're going to align the ring. Bit more. That's perfect, Anna, thanks. So let's go for an aortogram and let's see where we are, okay?
Yep.
Let's do it. So
nice.
I think it's pretty good, right?
Very nice.
So it's nicely aligned, the coronaries are open. So let's go for a pacing, okay? 120, Christian, please. Geza has started opening the valve. No, not start. I will tell you why. Okay, so please start the pacing. Wait a second. Yes, okay, let's go. So Geza is opening the valve. Some contrast Anna, please, just to. Very good. Okay. See, okay, stop pasting, please. There you go. Okay. So, let's see what we have done, okay? Some contrast. Okay, we are going to LAO. Please concentrate on the non-coronary cusp. There's an infolding there. Okay, let's do it. Eberhard, what do you think?
It's a little bit hard to see, but I think the position is actually
This
great.
is the right position.
It's high, although it doesn't make much difference, you know, the depth here with a permanent pacemaker. But I think you've done a really good job, Peter, as far as implant depth is concerned.
Yeah. So would you put it down? I would.
Yeah.
I would. So let's do it. Let's do it under like controlled pacing, 120, and that's it. Give us anything again. Geza suggested me to pull out the pigtail. Yes, I will.
Did you mention an infold? I can't see this from here.
You cannot see it from. Go to cusp overlap on the
No,
place.
don't worry about it. Just finish it.
Oh no. Let's see. The patient is stable.
So this tells you Peter and his team are very experienced. They're looking at the infold with the SAVI calcification. Many patients overlook this, but it is an important aspect.
It disappeared, Eberhard. There's no infolding.
Yeah, because it's Peter that's doing it. The valve.
Okay, so Geza will replay it for you.
Very
Please
good.
Take a look at that.
Eberhard, I think you always stress to see it in both views also, because sometimes eccentric compression.
So it's pretty suspicious that there is some infolding. Can you see it now?
Yeah.
Non-coronary cusp. There are the bridges.
Yeah.
The calcified bridges, but it disappeared. So it means that the valve kind of worked out itself. Okay, so let's put it down, okay? Menj nyugodtan vissza, Anna.
So you release it, right?
Yeah, so we went to LAO. So Geza, please pull the wire. Geza has pulled the wire just to ease the tension. Pacing, please. Christian has started the pacing.
Peter, this is Dr. Srinivas Kumar here. Some people have the habit of just before releasing, leave the valve in position for a few minutes and allow it to expand. Or you do you practice? Anyway, you have released it. That means you don't do it. But Eberhard, do you?
Actually, since I was talking too much, stop pacing, please. Since I was talking too much, basically I did it. Normally we don't do it. To be honest, So let's check whether the valve or the catheter has detached or not. So I just pushed the system a bit, see, and it got detached. So now it's safe to pull the wire even more, just to centralize the nose cone, and then the off.
That's a very important step
keep the wire in.
Get to the nose cone back while seeing it. Otherwise, sometimes it could catch the wire.
We are out. So Geza is closing the valve. So just give me a second. Would you please fix my mask again? I'm sorry. Thank you. Thanks. You can tell that I'm talking too much. So since there is, so the patient is intubated, let's go for a transvagal echo just to see what we have done so far, okay? Let's go for a sheet exchange.
Yeah, maybe you can pull the wire a little bit, but only minor.
We will in a minute, yes. I'm gonna exchange it to a pigtail.
I think from what I see here, the implant depth is perfect, Peter.
Thanks.
As Srinivas said, before you finish, I think it is good if you would verify the expansion into orthogonal views of the intensifier.
We will. Let me just exchange the Olandaquist to a pigtail. Because it will cause some leak anyway.
Yeah, you have the TE in place.
Yeah. So normally we don't have it, so we just check the valve with the transthoracic echo, but since the probe is down anyway, so let's just use it.
Interesting that the fold went away, no?
Yes. Yeah, so it means that it's a pretty good valve.
Yeah.
So it has a very, very good radial force.
Yes, coronary
Sorry, I'm
also
just looking.
visualize.
Okay, let me just flush the system. Okay, let's zero it. Nulla, légy szíves. Okay, let's add some pressure. So, can you see the hemodynamics?
No. You see the echo now.
You can see the echo, okay.
Yeah. Okay, now we see
you
it.
can
Okay,
see the hemodynamics.
that looks
okay,
good
there's
though.
no. Okay, so it looks looking pretty good, and there's a pretty good diastolic separation.
Very good.
So I think it's fine. Anna, please, let's just stay here. Let's just wait for the echo, and then angio after that.
Srinivas,
Monica,
you're
what
the
do you
boss.
think about the depth?
Looking good, no?
Csináljátok nekem.
Yes, there is no gradient.
No gradient at all. You can't have anything better than this.
Thank you. So let's just take a look at the echo leak, because you haven't had a chance to go for an aortogram.
It's a good practice to check on the echo also once I feel, sir. Many of the centers, they don't have, and they don't even check echo, but it's always
So
better.
what we do while Monica is working, and I don't know how much time we still have, but what we do, so we exchange the wire to a pigtail, and the first is to go for an aortogram after like 5, 6, 7, 10 minutes. And then, if there is no much paravalvular leak or any leak, then we go for a transthoracic echo. It's mandatory. And then, if there is no question, then we stop. If there is question, we put down the transesophageal echo. The patients are normally consciously sedated, so we can just deepen the sedation with some propofol, and then we just go for a quick transesophageal echo. But since at this time the probe was down, I just wanted to check it. Monica, what can you say?
The position is perfect for the TAVR, and there is only a trace paravalvular leak.
Trace paravalvular leak, thank you. And I don't know whether you can see that there is a remaining kidney shape. Can you see that? No, you can see it.
Yes.
And the short axis. But luckily there is no significant paravalvular leak, and we don't go for cosmetic procedures. So I think that Geza, what do you think? Shall we stop? Yeah. Eberhard?
Yes. I think,
Yeah, I think so too.
Considering the age of the patient and
Yes.
and the complexity of the case now, I think, I wouldn't be overly aggressive with a
Yes.
trace paravalvular leak. I mean, what he's done actually, the implant depth is perfect.
Correct.
Okay, so let's go for an aortogram just to see.
No, just don't disappoint us.
Actually,
In spite
self-expanding
of-
valve might expand little
So
also with
so much
time. and then-
comorbid
Shall I do
condition
from here?
is excellent result.
So please let me remove the pigtail from the LV. Kis drótot a gyerem, akarom mag csak úgy kihúzni. And what we could do, we could add only like 5 ml, and then we will not see anything. What do you think? Just not to disappoint you. We would never do that. Anyway,
Okay.
so here's a... Okay, let's do it.
Excellent. No paravalvular leak, really.
Very, very
Very
nice,
good.
Peter. Very, very nice.
I think that this is the end of the first step, if you agree with us. And thanks a lot for having us in Hyderabad. It was our definite pleasure to be with you virtually.
Thank you, Peter, for the great demonstration.
Peter, thank you very much. Obviously, I'm only chairing this together with my friends here, but Dr. Srinivas has the last word. Excellent demonstration. Your team is, as always, superb, and the judgment was excellent, and we wish you, the team, and the patient, of course, best of luck now with the next step. So, Srinivas,
Thank you.
Yeah.
You want to...
Any questions or any doubts from anybody in the audience before they close? I think they've shown very well. Thank you, Peter. And
congratulate you once again.
I think Eberhard, Fazila, big round of applause for them.